time off. Over to you, Dr. Hadidi.
Well, thank you so much, and good morning and afternoon for everybody who's watching us. I'll be sharing my screen. Hopefully, everybody is able to see the screen. So today talk is more of a really nice talk and dear to my heart. We do that in clinic with patients, and we like such a talk because at that time we're at a stage to consider stopping treatment for some patients, and I think this is an evolving concept in myeloma that is more accepted nowadays compared to back in the days where we thought that patients required treatments for the rest of their life or in terms until progression. So the talk today will focus onto a question if we can stop myeloma treatment and remain in remission. I'll start. Those are my disclosures. I'll keep them there for a sec. And the answer for this question, which I will bring up a little bit of data to support it, is yes. You can stop myeloma treatment and still stay in remission as a myeloma patient. The good thing about multiple myeloma is the fact that the developments have been happening now for the last 20 to 30 years. And we have clinical studies that started from that time, and we still follow some of those patients at various institutions here in the US. And we reported in the last few years, actually, 3 of the longest follow-up data when it comes to multiple myeloma in data that came from here, from Arkansas, where patients initially got treated with some of the novel therapies before they became approved and used more often in the community. So with this data, as you can see in the slide, now we have follow-ups of more than 15 years on patients. So we have a journey from the start till afterwards. And we treated in these protocols more than 1,500 patients, and we have more than 40% of them as long-term survivors. Now, there are a lot of changes when it comes to how myeloma was treated many years ago and nowadays. But from that era, there was no much good treatments initially, and many of those patients were treated with some sort of chemotherapeutic agents and high-dose chemotherapy and transplantation, as well as one of the of those new therapies that we use nowadays, including immunomodulatory drugs you hear like lenalidomide or Revlimid, thalidomide, or pomalidomide. Those drugs are under category of immunomodulatory drugs, and they were implemented through those protocols over the years. Later on, also, we have implemented the drug called Velcade or bortezomib, which is also considered at that time a novel therapy. Now, many of you as myeloma patients nowadays, they're taking this as a standard of care. But back in the day, those were studies where those agents were introduced to patients and compared to patients who got it or didn't get it. And we see how the differences were. So the good news about those were the protocols when we started to use products that actually work for myeloma patients. And we actually are lucky enough that we, in our institution, we still follow up patients now many years down the line, even when they stop their treatments, to see where they are. Are they still in remission? Do they have some of the myeloma protein acting up again? And how are they doing? So just to refresh your memories, this idea of how we treat myeloma evolved over the years. Even the concept of stem cell transplantation is being changed now as we speak. But the idea is, first, patient get diagnosed with this condition. And this condition is, sort of an end spectrum of an umbrella of other conditions. There are patients who have a precancerous condition, things we call as MGUS or monoclonal gammopathy of undetermined significance, as well as smoldering multiple myeloma, and then the actual cancer entity, which is multiple myeloma. And once this diagnosis is being made, multiple things play a role in discussing where the patient comes. Is the patient younger, older, good shape, maybe have some comorbidities, and many other factors play a role to decide on those patients being eligible or ineligible for stem cell transplant. And I think those terms are important to have in mind because those treatments did evolve over the years from the induction concept where patients get the first treatment, followed by what we call consolidation, which carries the stem cell transplant and other sort of multiple combination therapies, as well as the maintenance therapies. And the idea was before that patients need to remain on maintenance until disease progression. And I think this idea came from an era where we did not have better. We thought that everybody at some point would have, not be doing as well. So many people did not feel comfortable to stop the therapy. But the thing that was done in those protocols that I mentioned to you, the good thing about it was that patients got a treatment that were time limited. That means you don't get treatments forever, but rather you will get a treatment for a few years. And in those protocols, we treated patients for up to 3 years. So anything between 2.5 to 3 years of the whole sort of concept of treatments. And the other idea that I think is changing nowadays is what you can see in this slide, that relapse will happen. And while relapse can happen, it's not necessarily the case. There are patients that we see in clinic that never relapse when they stop their therapy. But the myeloma is a disease that can happen in a relapse fashion. So where patients may get a remission for a long period of time and later on may relapse. The idea of having, percentages is always important to patients, because when you see patients in the clinic, they want to know how often will I relapse if I stop therapy. And this is where we did not have much data before, but nowadays we're building up on the data that we have. And that actually required time. So what I would argue that it's been changing nowadays is, first, the relapse is not necessarily happening for everybody. And the idea that this induction chemotherapy did change over the years. So, for example, when I tell you the therapies that we use in this long-term therapy protocols, they included chemotherapy along with those, smart drugs, or the immunomodulatory drugs, or proteasome inhibitors. But nowadays, we got a little different on the induction regimens we use, where we're trying to use more myeloma-specific treatments. And many of the patients nowadays, they have a combination therapy with what we call triplet, meaning 3 drugs together, or quadruplet, which means 4 drugs together, as an induction chemotherapy. But regardless, our mindset as physicians, that we're still thinking that we need to treat patients forever. And that may not be actually logically even accurate, because patients may go into remission and keep their remission for a long period of time. And you may ask yourself, why I am taking a maintenance drug when I don't really have any cancer activity, either in the blood, in the urine, in the bone marrow, in the image. And even this, with the technology of this minimal residual disease, even with technology, we cannot see cancer. So why I'm taking something to treat something that is not there? So those are logical questions. And the good thing about this long-term follow-up is the fact that we treated patients with a time-limited therapy to start with. And that was in an era we would not use MRD to tell should we stop treatments or not. We did not use remission per se to stop treatment or not, but we treated all patients as a package. They get this package of 2 to 3 years of treatment, then they stop their treatment and see how they will do. So if you look into this, long-term treatment protocol, those patients get actually this induction chemotherapy. I will call it phase 1 treatment, where they get multiple treatments to control the myeloma. And then the stem cell transplant, which, is many of the patients may or may not get a stem cell transplant. This is when actually we give patients high doses of chemotherapy and giving them some of the stem cells that we stored previous, to kind of allow them to build up their blood. So it's actually a misnomer. It's not a stem cell transplant where you're getting cells, but rather you're getting a stem cell rescue after getting high doses of chemotherapy. The idea is, when we do such transplantation, we kill cancer cells at a very, very low level that may not be sort of taken care of by the induction therapy. And those protocols, what we call total therapy protocols in Arkansas, treated patients for 2 to 3 years of maintenance, or call it extended therapy, before stopping the treatments. And after that, patients stop therapy. Now, unfortunately, even when patients stop therapy, we continue to check on them. And this is sort of logical, because we want to make sure they don't get this disease acting up on them again. So they're still being monitored by their doctors in regards to blood testing, and even some bone marrow biopsies or imaging, to ensure that they remain in that remission. So this is sort of an overview of how those phases of therapy happen. It's a long journey. No, this is not like other cancers, for example, where patients may get few months of therapy and then they will be done. Myeloma is a long journey, but our goal is to make this journey a time-limited journey instead of going forever on treatments, trying to do that for a shorter period of time or a well-defined period of time. And what we actually reported in sort of a summary, if you look at patients who stop their therapy, the biggest question, how many of those patients actually will relapse and require other therapies? And you, as a myeloma patient, you may be on a spectrum of age. For example, we treat patients who are in really young age, maybe less than 40 years old, but the vast majority of patients with myeloma, they're 60 years old or older. So for us as a treating physicians, when we want to actually look at a given patient, my goal is to look into what the gap is in life because it's expected for people who live here in the US to live to the late 70s. And there are some patients who come from good family genes or their family members live to the 90s or even more. So the idea is that we need to close that gap. So for many patients, they say, okay, you know what, I'm getting those treatments, I'm stopping therapy. Do I will ever require treatments again? And with us looking at the long-term follow-up, if you look at those studies, some of them followed up patients for more than 25 years. So you're talking about a lifetime journey. And even in some of the studies where we initially incorporated thalidomide, for example, a drug that most people don't get nowadays because they get the newer generation lenalidomide, patients who stop therapy, there is more, 1 out of 4 patients, 20 years after stopping therapy, they remain in remission. So that's really a large number of patients. Now, you may ask yourself, what about the 3 out of 4 patients? Well, remember, myeloma is a disease that happened in the late 60s. So unfortunately, there are patients who may die because of other reasons at the older age. And there are patients who may relapse afterwards. That's not necessarily the case that everybody who stopped treatment will not relapse. But remember, patients, even on maintenance therapy, may relapse. The idea of having a maintenance therapy does not prevent relapse 100%. So this is where the patient in clinic logically asks, why should I continue on treatment if I am in this remission, for example, for this amount of year? So what we looked at is 10 years after stopping treatment, how many of those patients remain in remission? And you can see more than 40% of patients, they remain in remission 10 years after stopping therapy. Now, I know many of you are patients, and I don't really pretend to be a patient myself, but that's a big deal. If you can stop treatments for a long period of time without requiring a treatment, we don't know even how we will practice myeloma 10 or 15 years from now. We only have really good developments over the years nowadays. So many patients do really like the fact that they can get this treatment break, even if it lasts for a given amount of years. And remember when CAR T cell therapy became a thing, when patients start using it, even if they get a year out of it, they're happy. So what about patients getting many years of that? So I think really this is a very patient-friendly concept that we need as myeloma physicians to try to build up our future studies around, is to stop therapy. You can also tell how patients do even 15 or 20 years down the line. I told you around, one of the protocols, there's 1 out of 4 patients still alive and free of disease 20 years down the line. But you're talking about around 1/3 of patients at least 15 years down the line still alive and free of disease. And for a disease that happens in the late 60s, you're talking about really a closing gap for the vast majority of patients. Now, the overall survival, and many of you probably who deal with this disease for a long while, got much better over the years. Back in the early 90s, late 80s, many of the myeloma patients, when they get diagnosed, it's sort of a death sentence for them. Patients may live a year, less than a year, or maybe up to 2 years, even with the treatments that were not very friendly. But nowadays, a patient who come to the clinic, they're expected to live more than 10 years on average. But in those studies, there were more than 60% of patients alive 10 years after stopping treatment. And 40% alive at 15 years, and the average survival for everybody across the ages, across the disease spectrums, high risk, normal risk, all of those were more than 13 years. And remember, this is an era before even a drug called daratumumab or isatuximab or the monoclonal antibody was even available. So if you talk about adding this drug, you may be even having better results than this. So What I would argue is the are getting better. And what Arkansas did in the total therapy protocol that I feel is a good thing to the community of myeloma is the idea of giving a time-limited therapy. Now, we know that there are changes in the treatments over the years, and maybe some of the treatments that were used many years ago are not used nowadays. But the idea of having a time-limited therapy as a concept was proving to be really valid by such a protocol. So if you look, for example, in the 1990s, when the very first protocol was was done, the 15 years overall survival was not probably the best, around one-fourth of patients, but that was basically the transplant. And many people, are trying to go away from transplantation. But even in the era of only transplant, the long-term survivor, the advantage was achieved by some patients. The other thing is the fact that when we added more therapies like thalidomide later on, we got this to be improving, as well as the, bortezomib or Velcade that got much better with time. So what we're talking about is whenever we add more development as a community, we're getting better survivors. So the logic, why should we treat this myeloma forever if we're getting better with what we do? And nowadays, I would argue that the current treatments are even better. We have those monoclonal antibodies. Those are really, game changers when it comes to the treatment in myeloma. They're tolerable, probably more tolerable than other drugs. And, they also improve patients' both progression-free survival, which means living with no myeloma for longer, and overall survival, which means living longer, regardless of, of having myeloma or not. And that's very, very important. So what is the benefit of time-limited therapy? I think, probably quality of life becomes first. Lenalidomide or Revlimid can be tolerable by many, many patients. But there, I always say, taking no medication is better than taking a medication. And we know that lenalidomide, unfortunately, being still very effective drug, can cause things that affect quality of life negatively. For example, fatigue. Some people get really fatigued with it. The only time they know that they're less fatigued is when they stop it. And other side effects that could have been specific to a given patient. So quality of life get better with time-limited therapy, as well as lower costs. So believe it or not, we're living in an era where costs are big problem, and patients may have to pay co-payments, on their drugs, and that's something that we can, save if we do time-limited therapy, as well as this peace of mind. I think this idea of having curable or incurable cancer, if you ask a patient in front of you, many patients, when you ask them what's a curable cancer, they'll tell you, I get the treatment, I stop it, the cancer will not come back again. And that is what actually, if you look in the myeloma ward, we actually are able to achieve that. Compare that with the lymphoma, for example. Lymphoma is another blood cancer where patients get a treatment and then they stop their treatment. Some of them may have relapse disease, but many of them may not. And I think this ideology is what is currently happening in myeloma. And that gives patient peace of mind. So I still need to be monitored as a survivor of cancer by doing testing. And in case the disease relapse, I'll have options to get treated. But in case the disease did not relapse, I'll have this peace of mind, better quality of life, as well as less side effects of those drugs. And certainly that will result in better tolerance because patients, for example, when they don't get much treatments, they tolerate, probably other comorbidities in a better way. They may have better things to do for the other things that they have as a medical conditions. So, but we need to realize a few things. This time-limited approach in myeloma benefited most the standard risk myeloma patients. The good thing is most patients are standard risk. Most patients in myeloma are the standard risk myeloma. A limited number of patients, we call them high risk. Such benefit is not the same. Don't think about this as the same sort of benefit. For example, I'll get more nervous to stop therapy for a patient with high risk myeloma. That doesn't mean we cannot stop it in the right patient in the right setting, but it's not as easy as a standard risk myeloma. The other thing is age. Usually younger patients and may tend to do better. And I know age is only a number. I think well-fit patients usually do better. Patients with less comorbidities, many patients do actually work hard to keep their physical activity well. This is all helpful. Eating better, moving better, having good quality of life, that also help you out for your outcomes. And I think those patients who actually achieve deep responses, who are the ones that really do well. Now, I want to just give you a caution that there are some patients who may never achieve the word remission in myeloma, but they're living with us 10, 15, 20 years plus. And that's what we care most about. By the end of the day, what we care about is not shortening the life or the quality of life of patients. But remission can be achieved for many patients, not all patients who will live long. So this is something we need to keep in mind. There are subsets of myeloma patients who may never get rid of the myeloma protein, but they still do well. And the reason why I mentioned this is this achieving complete remission is one of the things that reflects into better outcomes, ability to stop treatment. Believe it or not, back in the community in myeloma, when somebody say cure, people were not taking that easily. But nowadays, even the myeloma community are coming up with a definition of cure because it's there. We're seeing it. But how can we define it well? And I think this is where the beauty of this is. So complete response was an old sort of, think about it, old currency of what's best. Nowadays, people are talking about something called minimal residual disease or minimal measurable disease. That means using technology, are we seeing cancer at the very low levels that the eye cannot see? And that is something that also, if it is negative, people usually on average do better than if it's positive. And you, as a patient or your treating doctor, may feel more comfortable to stop your treatment if you remain on that. For example, when we look at those studies that I mentioned for you, the best patient who did remain in remission are those patients who have this MRD negative or minimal, measurable disease negative for a long period of time. We call long period of time 2 to 3 years. So every year they do this test, negative, negative, negative. You stop their treatment, you repeat it, it's negative, negative. And that is actually give them the peace of mind, I stop the treatment, I'm doing the bone marrow, it's clean, the blood is clean. And in case there is something going in there, then maybe a plan to restart some sort of therapy is there. So, and usually patients who get all those treatments do better because, remember, not all patients are the same. Not all patients tolerate the treatments the same. Now, even this intention of transplant, not everybody you intend to do transplant on, they end up doing it. There are patients who may not be able to do it. And that doesn't mean necessarily bad. Even in these protocols that I'm just mentioned to you, with the intention of doing 1 or 2 transplants, even in the era of doing 2 transplants, there are only 75% of patients who are able to complete those transplants. 25% did not. And that doesn't mean necessarily bad, but there are patients who may have things in within it. Maybe they got an infection. Maybe they got a side effect of it. Maybe they're already in remission and they decided to skip the second one. There are other factors that play a role and that are very important. So when you decide on should I stop therapy or not, there are a few factors we need to keep in mind. Remember, myeloma it's called multiple myeloma. It's not one size fits all. It's not a disease that everything that applies for a patient applies to every patient. But there are a few concepts that apply for everybody. For example, if the response is really deep, like you have somebody in a complete response, we talked about this minimal residual disease negativity for a long period of time. This is where you feel more comfortable about the concept of entertaining stopping treatment. Then the risk itself is important. There are some myeloma physicians, for example, very recently, who wanted to rely on this minimal residual disease to stop treatment for everybody. So you say, I'll give a treatment. MRD is negative, stop the treatment. Maybe it was a good idea for the standard risk patients, but we learned it's not really a good idea at all for high risk patients because achieving this in a very short period of time doesn't mean necessarily you're done for high risk patients. For those patients, they may have longer treatments. Now, the biggest thing in this study, as I mentioned, it's 2, 3 years for everybody. But maybe for some patients, we need to go less. For some patients, we need to do more. I think this is where the future is for how long this for a given risk. And I think the previous treatments are important because remember, if somebody is coming with newly diagnosed myeloma, then this concept of stopping treatment is the most valid concept in that patient population because this is where this data coming from. This is for newly diagnosed patients. Now, what about relapse patients? That means they got something, they got the benefit, and then they have relapse disease. The idea is still, as of nowadays, to keep going with the treatments until progression when it comes to relapse disease. But I will tell you, this is also changing because nowadays we have all those immune-based therapies that may work really well. And I'll tell you, I treated patients, for example, who get some of those treatments. They stop them and they're many years down the line still in remission, even if they have relapse disease. But as a concept, we need initially to start thinking of stopping therapies for newly diagnosed patients at their time, and then to the relapsed refractory patients. And again, I think age and quality of life and overall health are important. We all of us treat patients. Maybe those patients are in their 80s and they may be on Revlimid and they feel peace of the mind. You know what? It doesn't cause me any problem, and I don't want to really stop it. So there are patient component we need not to ignore. There are patients who prefer to be in some sort of therapy. I don't find this wrong, but the idea of having continuous therapy for everybody, I think this is where we need to change how we think. So the quality of life is quite important. And I know when you stop therapy and you ask patients how they're doing, I'll tell you, well, we're back to life. We're doing things we like to do. And that sometimes for patients, I told you more than 40% of patients may last more than 10 years. So it's a sort of a big deal. Even if we say that after 10 years, the disease will relapse. Now, there are patients who will never have a relapse disease, but in case they relapse, with the treatments we have, I think we have really good hope that we put some of those relapses back to remissions or to control their disease. So this clinical decision process is specific to you as a given patient, and it cannot be done without knowing how the disease is, how the journey is, and how your tolerance is, and what your beliefs are. Because not all patients believe that you need to stop therapy. There are patients who are more anxious than other patients. But also you need to realize that even if you're in this Revlimid or lenalidomide, relapses could have happened even on that therapy. So the idea of maintenance came in from an era where the treatments were not as good as now. That's number one. And when an era where we thought we didn't have better. But nowadays, we have really good treatments, and the concepts of stopping therapy is not only coming from actually the data from Arkansas per se. If you look at the data coming from the UK, there is actually an idea now that patients who get Revlimid or lenalidomide for 2 to 3 years, they're getting the benefit out of it. The more you give it, you likely will not be preventing relapses. So this idea of limiting treatments in Europe is a big thing. So if you're in Europe, people don't use lenalidomide until progression. Many of them use it for 2 to 3 years, the way we used it here. And I don't think this is wrong, because what we actually have is time-limited therapy can result in better, and long-term outcomes that are really good. So that is the last slide, and hopefully we'll then open it up for questions. I think the hope is for the future. What I'm telling you here are studies that were started, some of them more than 25 years ago. So you need to realize many things happened, not only in the treatments of myeloma, but guess what? Even in supportive care. For example, if you get an infection in the COVID era, there was no treatments at that time. We lost many of our patients to the COVID pandemic. But nowadays, for example, this specific pandemic, if somebody get COVID, they may really be over it and get quickly to recover from it, different than that era. And this is how the medicine has been changing. The supportive care, the antibiotics, the antivirals that we have, the treatment support is quite important, and that got better. So my bottom line of this, that many of the myeloma patients we see nowadays are expecting to live normal life expectancy. And I always tell my patients, I see them, I know when I saw the young, one of the all the sort of longest follow-up we have on a patient here that we see in 39 years down the line of therapy and still a remission, and the patient in her 80s and still doing really well. That brings joy to us as clinicians who treat this disease, but also to the patient in front of us. And guess what? If somebody really stopped therapy for many, many, many years, and then their disease misbehave on them, that means they get some myeloma protein in the blood. There are treatment options that will be, available for them. Should they need treatment? Maybe they're at the stage of their life that they don't want to even get treated. So this is very important. So the studies nowadays are better. Those studies I mentioned to you did use actually older treatments, but this is very important. Those old treatments are also, resulting in old study starting times and long follow-up. So we know better how we can tell patients down the line. Now, many of the patients are getting treatments called CAR T-cell therapy. Those are really showing really great promise. And we'll get to know if this is even becoming more of a concept of using treatment and stopping treatments after such therapies. So the treatments are also could have been personalized in the future. So that means, if you're running a race, a marathon, some people are faster than others. They reach the finish line quicker. Should you continue kind of to ask them to run even after they finish the end line of the marathon? That's a big question. And I think the research that we have here will just increase the fraction of the cured patients. I do believe hardly that, we curing number of patients. It's really hard for me to see somebody 20 years of therapy in the clinic and you do the testing and they're still in remission to tell them they're not cured. They are cured, certainly. But we need to make this fraction of patients more and more because we still have, more than half of the patients likely not cured. We're curing roughly a third of patients with myeloma. So we need to increase this portion to make it most of the patients, hopefully, to be cured and be able to treat for a certain duration. So the last thing you need to remember that every patient is unique. Those statistics are important. Statistics are numbers. They actually apply for everybody on aggregate. They don't apply for a given patient. That means if you're a high-risk patient, that doesn't mean you always will do bad. There are many of the high-risk patients who do better than standard risk patients and the other way around. So that's very important. And I think those decisions, when you do them, don't do those decisions on one occasion. Think about it. That this stopping therapy may not be done in one session. Think about it. Bring up questions. And once you get all these things cleared in your mind, by the end of the day, you decide if you want to remain or not on the treatments. And this data supports that you can stop treatment and remain in remission even for a long period of time. I think that was the last slide, and then we'll hopefully allow for the good discussion here.
Perfect. Thank you so much, Dr. Al-Hadidi. I know um, I feel the excitement and I see the comments already coming in for the Q&A, just the thought of that time-limited therapy and knowing that this isn't something that has to go on for, the duration. So thank you so much.
Of course.
All right, so we are going to open it up for questions. If you're on already, go ahead and type those questions in the Q&A. We've got a lot that have already started in there. But if you're watching on YouTube, we invite you to join us at healthtree.org to participate. You'll just register for the event, get the link, and pop those in the Q&A. So just want to warn everybody, we do have quite a few already in, so I'm going to consolidate some of the questions. So if you don't hear your question asked directly exactly as you wrote it, just know that we're going to try to get to the essence of all of the questions. If we're not able to get those, I'll also send some follow-up information to people who entered those in the Q&A. So one thing that has come up a few times is just defining the difference between MRD negative versus remission versus, we hear a couple of different terms, complete response. Could you kind of walk us through all of that?
Certainly. This is very confusing to the patient because, for example, and let's say breast cancer, we do an image, there is no breast cancer, we're good, remission. In myeloma, we're a little bit greedy. We have the blood, we have the urine, we have the bone marrow, and we have the image. And we want everything to read clearly zero or negative to call, the levels of remission to be the best remission. But the call remission means when you look in the blood or the urine, the areas where we measure a myeloma protein, we don't see a myeloma protein. The remission has 2 degrees. There is called complete remission and stringent complete remission. The stringent means even with trying to check harder for this in the blood, we don't see any myeloma protein. So that is where remission is when it comes to the blood. And actually, if you look at the bone marrow biopsy, if you have less than 5% myeloma cells, this is what's called remission. But the MRD is a little bit a different level. The way I tell patients about it in the clinic, the remission, you likely will achieve it before the MRD negativity, but the MRD is something that I cannot see. So what we do to call MRD as positive or negative, we get a sample from the bone marrow. That's the only test that we need to do only from the bone. You cannot do it in the blood. And we try to count at least 2 million cells. So that's how we call it successful. 2 million is a big number. And we try to see if any of those 2 million cells are cancer cells. And if we see any cancer cells, we call it positive. If we see no cancer cells, we call it negative. So MRD negativity is technology test to tell us if there is myeloma at a very, very low level that I cannot see. And even this technology, think about it, is getting better. There is a test we use where if you give this test 100,000 cell on the front of them, they will not miss one cell that is cancer cell. But there are cell now tests that look at 1 million cell at one time and they don't miss one. So those cells are getting better. There is actually 10 million and 100 million. They're getting only better in quantifying very low levels. So that is what we call as MRD negative. Now, the images are supplementary. So to call remission, if you do an image, let's say a PET scan, we don't like to see a spot that is still hot or appearing to be active because some patients may have the bone or the blood as clean, but they still have an image that's still showing as myeloma. So in myeloma, we like everything to tick. No image problem, bone marrow is good, blood, urine, all of that is good. And that is what we call this is remission for an MRD negative remission. Hopefully that helps.
Absolutely. I know there's a lot of different terms that I know, especially as a newer patient, you may hear and not understand. So I appreciate you going through all of that. We've got a couple of questions about patients with like T1114, high risk, anything like that. What are your thoughts in that regard? Would that be a situation where, in the future with these newer medications, we may be able to come off treatment, or is that yet to be seen?
Yeah, so the 1114 is that means part of the chromosome 11 travels to chromosome 14. We call that translocation 1114. That is still considered to be standard risk myeloma, but it's a very selective number of patients where actually many of those patients may never get MRD negativity, but they still do really well. So that's important. I would say a portion of patients, and they may actually qualify to certain drugs that other patients with myeloma do not really respond to it. So the 1114 is still considered to be standard risk. So the good outcomes are seen with 1114. In practice, we see those patients to be maybe slower to go to remission than the other average patients, but they still do well. Now, the high risk, there is, changes in the high risk definition over the years. And that's confusing even to the usual community oncologists because those changes every time. And nowadays, it's considered to be two risk factors together mostly. So that means you have two of the things that we believe that put you at high risk. And there are many of them has to do with chromosome 1, either extra copies of it, with deletion of some part of the chromosome 1, as well as those translocation, we call them 414, 1416, 1420, or deletion of chromosome 17. So this is where your doctor will review this kind of genetic testing and tell you where you come when it comes. Now, important that this is changing, evolving. There are patients who come and say, I'm in high risk. When you talk to them, they're not really in high risk, and the other way around. It's important to keep that in mind. And what I would say in the future, we as a community, we should focus mostly in this really high risk group to make sure that we close the gap for them, because this outcomes are not as good for the high risk myeloma patient as of now. But remember, we in the community of myeloma are coming up with clinical studies to focus on high risk myeloma and hopefully using those bispecifics, CAR T, and all of that to hopefully get to us there. So for the high risk, I think the research will bring us there in the future in a better way than where we are now.
I love it. Thank you so much. I know sometimes in the high risk community, there's a feeling that, they may not have as many studies available. So it's good to hear that, with all these newer treatments, we're seeing that. We've got just a question about secondary blood cancers, specifically after like Revlimid maintenance, other medications. Um, are there a percentage of patients that generally develop that, and what does that look like?
Yeah, and I think that's a very valid question, and that's a concern for patients. And that the idea is Revlimid or lenalidomide increase risk of certain blood cancer and other cancers, as well as the stem cell transplantation, or what we use, the chemotherapy that is related to the stem cell transplant. Now, the good news is now we have really long-term follow-up on those patients. And there was a big entity called the CIBNTR, where every kind of center sent data to them. And what they found that the risk of it is even the long term is less than 5 to 6%. So, and even our data here in Arkansas, where patients get two transplants, the risk 15 years down the line is less than 7 to 8%. So what does that mean? That means if you get all those treatments, including the transplant, the Revlimid maintenance, and you stop your treatment or, and you're followed 15 years down the line, you're still alive, you have less than 10% chance on average to have secondary, a blood cancer or something that really is worrisome. And that's really good that the percentage is low. Um, the idea is the fact that even if you don't get some of those treatments, patients who tend to have a cancer, they're at high risk of cancers in general. But we worry about the blood cancers because those are hard to treat cancers, and we don't really have really good treatment options for them. So my advice to patients, usually whenever they're done with treatments or still on treatments, to do the screening for the other cancers because those are treatable. And for example, a small skin cancer or so. But when it comes to the blood cancers, that's a concern. Even with the CAR T cell therapy nowadays, we're learning that there may be some risk of the secondary cancers that could have happened. So unfortunately, you will always need to be monitored for that. But the risk is not as high as we believe. So it's not like if you're living 15 years down the line, you have, very high chance of getting a blood cancer. It's still less than 10%. We hope it's 0%, but it's actually sizable there. But with the benefits that we have, I think that's some of the patients when they know that they still, what you said, they'll take the risk in a way. Otherwise, if the patients don't get treated, unfortunately, myeloma will not allow them to be alive for 15 years.
Absolutely. Absolutely. We've got another question that just asks about, if you do a time limited therapy and you relapse, would you need to stay on therapy until you relapse again? Or after a single relapse, would you be able to go off treatment again?
So I think that's a very smart question. I think in the era nowadays, we may come to even for the relapse disease to use time-limited therapy. We're not there yet. But in the research, for example, many of us have protocols nowadays to try to stop certain treatments, even for relapse disease patients, and monitor those patients and see if they need the treatment to restart the same treatments. Try to give them sort of a break. And we actually have patients 2, 3 years after stopping treatment after relapse disease who still remain in remission. So, as a concept, it can be applied, but not as much as a newly diagnosed. So, the concept applies more for newly diagnosed patients before relapse disease. The idea when relapse happen, that another relapse are at higher risk to get another and another relapse in a way.
Perfect. Thank you. Let's see. Just filtering through a few more of these questions here. Let's see. That's another remission question. I guess another good question here is after you stop treatment, how often and what type of monitoring is recommended?
Yeah, I think that's $1 million question. To be honest, so what we do, I mean, that does not necessarily mean that the only way to do it. But those patients who stop treatment and they're doing really well in deep remission, we actually try at least to see them once a year. Do a bone marrow once a year. I know bone marrow is painful. I don't suggest that you need to do it every year, and that's a patient by patient decision. But this is a way to check this MRD thing that people really need, like, interested to know what it is, as well as an image once a year. That when it comes to the major testing, bone marrow and image. But when it comes to myeloma numbers, I always, almost everybody who stopped treatment, I'll tell them to check their, blood testing at least every 3 to 4 months. This way, you get a peace of mind that you're not really ignoring this. You're doing a blood test every few months. And in case anything that is concerning in regards to myeloma, but why not even this blood cancer risk that we just mentioned? This is something that you can catch by doing such blood testing. So doing this every 3 to 4 months as a blood test, as well as a bone marrow biopsy, consider doing it once a year, as well as an image once a year. I think that's what we usually do for those patients who stop treatments.
Perfect. Yeah, there was a lot of questions about monitoring specifically, so thank you. Got another question just about what it looks like if you do have the time limited therapy. Is it something where you do, you know, step down the dosing a little bit at a time, just making sure everything looks good, or just a cold turkey type situation?
Yeah, I think it's sort of a step down in a way because the induction therapy, think about it, it's multiple drugs together for a short period of time. Then the transplant play a role. And after transplant, will be less therapies than initially, and then stopping the therapies afterwards. So those therapies will be tailored in a way to how what will be sort of tolerable. There are many patients, for example, let's say a given dose of lenalidomide may not be good enough for them, so it'll go down to a really good sweet dose for them. So to the point that will be tapered until it's stopped. But when it's stopping, we just call it stop. We're done. We stop that dose that the patient is on.
Okay, perfect. I've got a couple of questions here just about restarting the same treatments after a break in treatment. So, if you did have a patient relapse after they had stopped treatment, would you go back to something similar or perhaps look at something different?
That's a great question. I think that
Mhm.
it depends. It depends on for how long they've been off therapy, off treatment. Let's say like you have somebody, you stop treatment 6 years down the line, they have a relapse. Then maybe doing the same treatment makes sense. But let's say the worst case scenario, which we don't see much, but you stop treatment a year after, 6 months after you got something. It may not make sense to use the same thing because likely this is, even if somebody remain on it, they likely will be having a problem. So switching to a different sort of drug class is possible. And the reason why we do that nowadays is the fact that we have plenty of different options that we can choose from. So it's not like we're forced to choose from very limited things that sometimes some other things may better. And that also depends on side effects. Let's say that you got something before you didn't tolerate as well. We don't really just, start it again, maybe try something more tolerable.
But there's a lot of new options and a lot more that are on the work in the works right now. So, um, a couple of questions just related to the study where a lot of them were receiving a stem cell transplant, and I think you mentioned also that there are um, newer studies, or people are looking at outside of transplant. Are they looking at the possibility of stopping treatment as well?
Yeah, I think without a transplant, as of now, the mindset, at least for us as treating physicians, are not in the way to stop treatments. And I think that has to do with a few things. First of all, usually the patients who are not getting a transplant, they tend to be in general older, may have comorbidities. And by that time, the idea is to try to control their disease for as long as they will live, in a way. And those treatments tend to be more gentle on them and so on. But as logic, you can still apply the same logic with or without a transplant. I think the transplant may make it easier because we have data to support that after you stop it after transplant, you still can do well for a long period of time. We did not have such as robust data as this. And most of the protocols that treat patients who are transplant non-eligible, they meant to be continuous therapy. So patients continue on that treatment. Now, over the years, many researchers did look at patients who stopped treatments, and many of them they still do as well. Now, to that point, an era before is not as this era. Nowadays, we have those immune therapies, and I would argue using some of those immune therapies, you may be able, even for transplant non-eligible patients, to think about a research that could have caused time-limited therapy. But in practice, we're still not there. So for patients who are transplant non-eligible, who did not get transplant, it may be harder to consider a treatment break for them or stopping treatment on average compared to transplant patients.
Okay, thank you so much. Just got a question about imaging tests. So, what would be the best test to indicate active myeloma?
Well, that's a great question. The thing is that, there is also access things. We need to keep that in mind. There are certain, your certain doctor where they work, they may have access to one or more the other. But X-rays are not good. Let's start with that. X-rays, we don't like doing X-rays in myeloma. They don't really show as much. So we have what we call advanced imaging. That means the better imaging. And there are two modalities, the PET CT scan. So the PET CT scan is a more of a CAT scan, and an MRI. Now, it all depends on where you're looking at. The MRI is likely the best test for bone. So usually doesn't miss as much of any bone lesion, the MRI compared to the PET scan. But the PET scan is as good as it can be. So I think either one of them are good enough. Now, many you can consider doing both of them in certain scenarios. Some of them combine both of them, but at least either a PET scan or an MRI. And the MRI has also different modalities. There is MRIs that looks at the whole body MRI. There is MRI that looks specifically at the activity of the lesions. We call that diffusion limited. And those techniques may not be available everywhere, but the bottom line is some sort of advanced imaging, either PET CT scan in case MRI is not available or the other way around.
Perfect. A couple questions just about non-secretory or oligosecretory patients.
Mhm.
Um, is there any difference in these patients, did you see, as far as if they're able to stop treatment?
Yes, I mean, I did stop personal treatments on patients who are actually non-secretory. And to the audience, non-secretory myeloma means when you try to measure a myeloma protein in the blood, you don't find it. But when you do a needle and you get the bone marrow biopsy, you still see the cancerous myeloma cells. But for a reason or another, those cancer cells are not producing a protein you can measure in the blood. That we call that non-secretory or oligosecretory. That means very, very small amount of myeloma protein. So those cases could have happened from the get-go. That means somebody got diagnosed with it, or they get at a relapse. That means they had a protein, they got treated, and when they have a relapse disease in the future, they have non-secretory disease. So non-secretory disease, there's a good fraction of patients with myeloma who have it. They have lesions and so on. The concepts also apply. But the difficulties there is the only way you can monitor such patients is by doing imaging. And maybe in that patient population, you need to do more frequent imaging because there is no blood testing that you can do to monitor the blood activity. We usually in myeloma, we try to measure the blood, and whenever the numbers are really, really low or zero, then if you do the image, you kind of confirm what you think already is there. But in this non-secretory myeloma, we may need to rely more on imaging more than usual.
Perfect. Let's see. One question, as far as like stepping down therapy, if they're on like a four-drug regimen, what does that typically look like? Are there medications that you would cut back first, or
Yeah.
does
So
that
in the
look like?
most of the current era treatments with the four drugs, they will be dropping to two drugs. Now the details can differ, and according to some patient related side effects profile as well as disease characteristics in general. But lenalidomide is one of the drugs that most patients remain on, which is the oral drug, as part of the 1 to 2 sort of treat drugs that they'll be on for a long period of time. So usually we're starting with four drugs. That's the quad therapy, a transplant, then dropping to 1 to 2 drugs as the maintenance. And after a while of that is to try to stop the drug. And as I told you, people were hesitant to stop treatment, but nowadays actually even the studies are trying to drop some of those drugs after certain time because people are feeling, you know what? First of all, that's more patient friendly, but after all, you still get what you want to get. You get this long-term remissions and good overall survival without subjecting the patients for lifelong treatments.
Okay, thank you so much. Um, Trying to kind of combine a few of these here just so we can answer more questions. We're getting close to the end of time. So let's see. And that's been answered.
You're
We got
having
a lot of great
hard
questions.
job searching, and there's more than 60 questions there. So,
Yes.
well,
And
sorry
so
if we have
again,
to go through
yeah,
some of those.
I was going to say as well, if you didn't hear your question spoken exactly as it was said, hopefully you got the essence in there as well. Um, and I think you touched on this a couple of times too, that is it reasonable and is it a situation where you look at how the patient is dealing with it mentally if they don't feel like they can go off a medication, they're worried about relapse,
Yeah.
is reducing better than stopping
I
in
mean,
those
I'll tell
cases?
you. I mean, I always tell patients you always deal with many, many patients, but you never feel what they're feeling. And some of them may be
Mhm.
worried. And I think I'll take that very personal. Whenever a patient in front of you is able to tolerate lenalidomide, and they're having a peace of mind that they want to remain on it, knowing that the option that they can stop it and they want to still do it, that's very reasonable. Because, for a given patient, that may help their anxiety, number one, they're tolerating it well. And that's, I think it's very important. So this is where personalization happen and also giving the patient time. I hate to stop treatments all like on, cut it all, cold turkey. No, you need to give time and introduce the concept. Think about it for a few months. Think about it. And then you may come to this. But to be honest with you, the vast majority of patients would actually, when you tell them about it, they'll tell you, "Oh, take me off the drugs." They don't want to remain on it. That's the vast majority of patients. But we still have some maybe not be a little hesitant. I think this is a case by case, need to understand why this hesitancy are and how much tolerance are there, and then take it at that time. Dropping down the dose to be a tolerable dose, I think that's are all good maneuvers.
Okay, perfect. I think I've gone through a couple of times, and I think we've got to the meat of most of the questions. Again, audience, you do have some questions that are specific with labs and different things like that. So I have gotten to the meat of most of them. If you do have any specific questions, those are great questions for your doctor. If you need a second opinion, we've got resources to help you reach out and get a second opinion as well. Were there any questions that you've gone through, Dr. Al-Hadidi, that you'd like to touch on real quick before we
Yeah.
wrap up?
I think they're all smart questions, which is really good.
Yeah.
I think, some of the questions focus specifically into, the monitoring according to the numbers. I would say there's some of the concepts that have been mentioned there is about having a myeloma protein in the blood, which I try to mention some of it, that there are patients who may never get their myeloma protein to zero. And this is not a small number of patients. I personally have many of those patients. It's a little bit, not very nice in a way that you don't call them there in remission. But if they remain to have this 0.2, 0.3 in protein for many, many years, that's by itself is a good thing. That tells you that whatever is going there with a very stable fashion. So this data still apply for such patients who have very low levels of a myeloma protein for a long period of time, and they still do well. Those studies I mentioned did not really judge the stopping and restarting treatment on any of the MRD things. People are trying to study that nowadays, but that was sort of this is the package of treatment. You stop it, and this is what you get, which is you have more than 30% chance of not requiring treatment in, years down the line, which is really good. But maybe it could have been shorter for some or longer for other patients, and that's where those numbers could have helped. The other thing I'll also notice in some of the questions is the fact we need to be a little careful with the M protein. Specifically, sometimes you can have an M protein where you don't have myeloma protein. That's something you talk to your doctor about because some of the immune cells appear as if they're myeloma protein when they're not. There are patients with myeloma I have in remission. Their test reads zero point 0.5 myeloma protein, which is not real. So I think those are a few things that I will warn people about.
Perfect. Thank you so much. I know, again, we had quite a few questions. We tried to get through to the meat of them, and really appreciate all of your really in-depth and thoughtful answers to our questions today, Dr. Al-Hadidi, and thank you for your presentation as well.
Sure, thank you all, and hopefully we'll continue to get better at treating this disease.
Absolutely. Thank you so much. With that, we will go ahead and close out today's meeting. So I just wanted to remind you guys again as well that we do have our 2 to 3 minute survey. We really appreciate you taking the time to answer those questions. It's going to appear as a pop-up once you close out of Zoom. This just helps tailor our efforts towards topics that are most meaningful to you. I've got on our screen several upcoming events that I'd like to highlight. So on Tuesday, August 5th, we have our bi-monthly blood cancer financial Q&A where you can get expert answers to your treatment costs and support questions. When you register for the event, you'll have the opportunity to pre-submit questions that our financial advocacy program manager will answer in depth. We also usually have time at the end for a live Q&A. So if anything comes up during the webinar, you're able to ask those questions as well. Our fourth annual Black Health Movement Challenge will be held virtually Friday and Saturday, August 15th and 16th from 8 to 5 p.m. You can walk, run, dance, or ride your bike to raise awareness, advocate for greater Black representation in clinical research, and support the African American blood cancer community. On the 20th of August at 3 p.m., we're hosting a special event for all blood cancer communities featuring fellow myeloma patient Jeff Abram. Many of you already know Jeff from his popular chair yoga sessions. This time, we're excited to invite others across the broader community. So make sure you register for that and any other of our upcoming events through healthtree.org. I'll also send it in the follow-up email. I just wanted to highlight our exciting new Connect to Cures events. These are live events where you're able to meet directly with other patients in the blood cancer community. I've got all of the upcoming events on the screen. So if you live in or near any of the cities, we're looking for people to help spread the word and join in the event on the day of. I'd like to again thank our sponsors, Adaptive, Pfizer, Johnson & Johnson, Amgen, and GSK. And lastly, thank you again, Dr. Al-Hadidi, and thank you to our community